Thank
I
you.
wanted to talk to you afterwards.
Sure.
Okay.
Hi, everybody. Welcome to Congenital Heart Academy. We are very, very happy to have all of you with us today. We are going to wait just one more minute. In this meanwhile, I'm going to show the video of the World Congress of Pediatric Cardiology and Cardiac Surgery while we wait for our other colleagues to join when it's going to be sharp in the hour, inviting all of you to please join us on this meeting that is going to be awesome. This meeting is going to be awesome, guys. I hope all of you can join us next year in Washington. It's going to be great. Please, if you are not from the US, please run to have your visa done. We are having a lot of delays on the US visa. So please, if you need a visa to go to the US, work on that in advance so you won't miss this amazing opportunity for your career. And I'm very happy to have Dr. Norman with us today in this meeting. I just want before, there was a very great symposium of CCTGA made from our colleagues from Toronto, from Sick Kids. This entire symposium is available on our YouTube channel. So if you're interested in CCTGA, it covers all the aspects of this disease. So please take a look. It's a very, very nice symposium. We want to invite you for the 19th of December for Dr. Silverman. A meeting is going to talk about the ecomorphological correlations of the VSD. And I'm going to type on the chat box the link for his website. He has all of these chapters that he talks to us as a book. This book is amazing. So I advise all of you to take a look and to buy. It's a very inexpensive for the content that it provides. And join us on Tuesday on the December 19th for this meeting. No, Monday, right? Yeah, Monday. And now with you guys, Dr. Meryl Cohen with a very interesting topic, imaging in the ICU. Thank you very much, Meryl, for doing this for us today.
Thanks, Grace, and thanks sorry, let me just fix that. Okay. Can you see that?
Not yet.
Let's see. share screen.
Yeah, now we can.
Now you can?
Yes.
All right. Yes, we're good?
Perfect.
Okay, good. Good morning, afternoon, evening, wherever you may be. It's nice to see you all again. Today I'm going to be talking about imaging in the cardiac intensive care unit. It's a place I spend a lot of my time as an imager. So when we're doing imaging in the intensive care unit, if it's a isolated cardiac unit, or if it's a pediatric intensive care unit, from the standpoint of cardiac disease, we obviously diagnose preoperative identification of congenital heart disease quite readily in this realm. And for the majority of patients who undergo cardiac surgery, a preoperative echo is the only modality needed prior to going through their surgical procedures. It's also a place where we do postoperative surveillance of the repairs that our surgeons and interventionalists have done. And it is a place where we will often be imaging in a crisis situation. So acute onset of heart failure or hypotension, cyanosis, and then signs of pericardial tamponade. What I'm going to focus my attentions on today is monitoring of patients who are on various forms of mechanical support. But you need to be prepared when you echo in the intensive care unit. It is a very unique environment to be imaging in, and of utmost importance is infection control protocols. These are a group of very vulnerable patients. Some of them have open chests. They have central lines placed or cannulas in place. And so it is essential for us to be sure that we do not infect the patients when we're doing the echo. So we use sterile ultrasound gel in this setting, and we gown, glove, and mask to try to prevent infection. It's also important that you as the echocardiographer need to pay attention to acquiring the images. And so really you're not paying attention to the hemodynamics of the patient. And it's very important to identify a team member, usually the bedside nurse, to monitor the patient during the imaging, because echocardiography, though we say it's a non-invasive modality, it really is invasive in the sense that you're putting pressure on the chest and belly of these patients. It can cause hypotension, it can cause rhythm disturbances, and so somebody has to be monitoring the patient. And then it's also important that the patient be lying relatively still and that we assess their hemodynamics in an ideal situation. And so if a patient is crying or thrashing about, we can't acquire the images appropriately. And so sedation should be used when possible. And then for very critical imaging, and certainly in the setting of imaging mechanical devices, the care team should be present as we're imaging the patient so that the information is communicated effectively and in an extremely timely manner. They can see exactly what you are seeing. So we'll start with ECMO, extracorporeal membrane oxygenation. There are two types of systems that are used, the veno-venous system and the veno-arterial systems. The veno-venous system supports the lungs and the veno-arterial supports the heart and lungs. And all of these require round-the-clock team effort. And these systems provide support as a bridge to potentially transplant, but usually to other forms of mechanical support or hopefully to recovery. And you can see from the equipment that we have really limited access to the imaging window in these patients. There are multiple caregivers at the bedside. The equipment takes up a lot of space, and often these patients have open chests. And so what are we trying to evaluate in this setting? Well, obviously we want to look at ventricular performance as well as AV valve and semilunar valve function. We want to look at the status of the atrial septum, particularly in single ventricle patients, or in patients who have LV failure, who may develop LA hypertension from their elevated end diastolic pressures. We want to make sure the pericardial space is not filled with fluid, that there's not clot in the heart, and then to look at extracardiac structures such as cannula position to make sure it's appropriate, and whether patients have other reasons why the circuit may not be working well, including Blalock Taussig shunts. So I'll start by looking at the veno-venous ECMO system, and this is used for acute respiratory failure. So it really acts as the pulmonary circulation or the lungs, and we only use it in patients who have preserved ventricular performance. The most common system is this Avalon catheter, which is a double lumen catheter in the venous system. You can see a port in the inferior vena cava, which takes the blood out, and then the blood is placed back in the right atrium. So the deoxygenated blood is drained from the inferior vena cava. Then you have an external system which removes the carbon dioxide and oxygenates the blood, and then it's pumped back into the right atrium where it flows across the tricuspid valve, ultimately to the pulmonary and systemic circulations. And this is what that looks like. Here we can do echo-guided cannula placement. You can see on the image on the left side of your screen that a cannula is being placed into the inferior vena cava. And the lumen, the second lumen that you see in the middle of your screen should be ideally directed into the right atrium and be free to allow flow to get across the tricuspid valve. And you can use color Doppler to assure that that lumen is unobstructed and providing the flow it's needed. This subcostal sagittal view, where you see both the superior and inferior vena cava at the same time, is really ideal for this kind of catheter placement. And it is, we're able to do this in babies and young children. Sometimes it goes wrong. Here's an example where the cannula is placed way too deep in the inferior vena cava. And you can see that that port or lumen that's supposed to be free within the right atrium is actually being obstructed at the level of the inferior vena cava and hepatic veins. And so this patient had desaturation, and we wanted to find the cause, and we found it. And then the catheter is pulled back and placed more ideally and improves oxygenation after this repositioning. Here's an example of something you never want to see. This was a very difficult cannula placement. And what you can see here is that the cannula is actually up against the wall of the right atrium rather than in the inferior vena cava. And unfortunately, it perforated the heart. And you can see that cardiac tamponade occurred as a result of that. Sorry, the images are not playing very well. So it turns out that echo is much better at assessing cannula placement during this type of procedure than chest x-ray is. And we can look at cannula position, and in this paper that came out a number of years ago now, about 13% required reintervention based on these echo findings. And the chest x-ray did not detect these abnormalities in 8 of the patients. And so we really, we make sure that we're available to these teams to provide this. And most of this type of cannulation is done in our neonatal intensive care units for patients who have acute respiratory distress, or in our pediatric intensive care units, usually for life-threatening forms of pneumonia or terrible viral illnesses, as we're seeing right now. And then ventricular arterial ECMO is for oxygenation and cardiac output. You have drainage of the blood from the venous system for carbon dioxide removal. It's pumped back to the aorta after oxygenation. You can cannulate either through the neck or through the sternotomy if the patient has been in the operating room. And this therapy is used for cardiovascular collapse, for ventricular stun after cardiac surgery, for myocarditis, and can be used as a bridge to other assist devices or transplant if an organ becomes available quickly. And so what are you looking for in this setting? After cannulation, we want to try to identify cannula position, ventricular performance. If we know that the patient has significant aortic regurgitation, this can cause distension of the left ventricle and inadequate myocardial protection. So it's an important thing to identify. We look for chamber size, particularly left atrial distension in the setting of LV failure, because that can also affect the performance of the ECMO circuit. And then, of course, pericardial effusion. So here is a cannula and a transesophageal echo that is a little deep in the right atrium, but you can see that the end of it is relatively free and is working relatively adequately. Whereas in this patient, you can see that the cannula is up against the wall of the right atrial appendage. And so that's why the circuit was cutting out. We identified that problem, and the catheter was repositioned successfully. And then we want to, once the patient's on ECMO, we want to try to assess for residual defects, any type of shunts, arch obstruction, pulmonary artery obstruction, or AV valve regurgitation. And this helps us to determine if the patient is going to need a reoperation to be able to get off ECMO support. And of course, many of these patients will require additional forms of imaging and may require cardiac catheterization if we can't answer those questions. But you can see that AV valve regurgitation on full flow with the left ventricle somewhat distended is a little bit different than it is after a wean, where you have higher afterload and there's more AV valve regurgitation. So it doesn't give us a completely clear picture when the patient's on support, but we try to identify as many of these residual lesions as we can. And then sometimes atrial septostomy needs to be performed. Here you see a patient where the left atrium is clearly quite distended. And when they looked at what atrial communication the patient had, the mean gradient across that was about 20 millimeters of mercury. And so this was a very high pressure situation. And then the patient was taken to the cath lab and a balloon dilation of the atrial communication was performed. And you can see that the left atrium has now decompressed somewhat and there's better performance of the circuit. We perform weaning trials. These are sort of protocols that are done to try to help determine if the patient is ready to be separated from ECMO support or if they're going to need to go on to additional type of support. And we assess this performance as we decrease the flows, looking at measures of ventricular performance such as shortening or ejection fraction, end diastolic volumes, the VTI of the aortic output. And though echo parameters do show us some information, alone they do not reliably predict success of separating somebody from ECMO support, but they're useful in conjunction with other hemodynamic data that's available to us, such as the mixed venous saturation, arterial pulsations, and lactate. And it's very important that we record the flow rates on the image with annotation to know where we are in the wean, and then use our consistent windows for comparison. So you can look side by side at the same image at different flow rates to help us assess ventricular performance and other measures. Moving on to ventricular assist devices, this has really transformed the way we take care of children with heart failure. It's really targeted to assist ventricular performance and is a much longer term therapy than ECMO and better for the patient. And it, in many cases, especially for older patients, it allows mobility of the patient so that they can undergo rehabilitation, physical rehabilitation to make them better candidates for transplant, and also allows some of them to go home and actually go to school and participate in their daily activities of life. And in adults, it has transformed heart failure as well and has become a destination therapy. And this is somewhat old data, but you can see that the use of VADs in children has increased dramatically over the last 2 decades, and this number continues to go up. And there are 2 types. I'm not going to spend too much time on this because it's really out of the scope of this talk, but there's the pulsatile type, and the continuous rotary type that are used in various situations. And the Berlin heart has allowed us to perform ventricular assist devices on much younger and smaller patients. And it's paracorporeal and pulsatile, and you can use it in babies as small as 2.5 to 3 kilograms. And it can be used as a right ventricular assist device, a left ventricular assist device, or as BIVAD, both device. And then the HeartMate is a device that now is used for older children and adults. It has lower mortality, fewer complications. It's relatively easy to implant, and the outside apparatus is less cumbersome, and so patients can walk around like this, and it's almost not noticeable that they have it. And it's really allowed our children to have much better quality of life while they're on support. And there are all sorts of newer devices that are coming out at all periods of time. And the only thing I would say about that is each device, if it's going to be used at your institution, requires education on how and when to image and the goals of imaging, and protocols should be developed for every type of device that you use in your ICU. So when we're doing pre-implant assessment, we look at cardiac anatomy, device, that helps dictate the device choice and where we're going to place the cannula. The cannula can sometimes be placed in the atrium instead of the ventricle. We want to identify if there are intracardiac shunts to see if there are any risk to have emboli. And it's also important to identify if there is valve regurgitation, AV valve regurgitation, or semilunar valve regurgitation, depending on if it's an RVAD or an LVAD, because this can affect the device filling and output. And you want to identify if there's potential for interference of the inflow cannula, either because there might be clot at the apex of the heart or significant left ventricular hypertrophy, which can impede filling. So here's an example of trying to identify if the patient has an atrial communication. We tend to do this by injecting contrast, agitated saline, to look for right to left shunting. And you can do, in this transesophageal echo, we do it by color Doppler as well. And sometimes in contrast to patients who are on ECMO who may need an atrial communication opened, patients who are on LVADs may need it closed to try to prevent the risk of emboli. And then patients who have LV dysfunction may also have RV dysfunction. And this is something we try to identify before placing the LVAD, but sometimes RV dysfunction occurs while the patient's on the LVAD. And this can be seen in the setting of significant tricuspid regurgitation, elevated central venous pressure, and can limit LVAD filling. I'm sorry that that image was not playing, but this was to show you that this right ventricle was working quite well. And you can see this very dilated, poorly functioning right ventricle on the right side of your screen. And so this can help us determine if an RVAD is needed as well. And when you're thinking about intra-op and follow-up assessment of VADs, you need to assess the cannula's position to look for kinking or abnormalities to the flow. Doppler interrogation of the cannulas can be performed. We again continue to assess for AV valve and semilunar valve regurgitation, ventricular size and septal position to help determine if the VAD is flowing adequately, the RV dysfunction that we talked about. And with regard to RV dysfunction, we look for dilation, and we can use some quantitative measures of ventricular performance like fractional area change or TAPSE. And then we look for thrombosis or vegetation as well, and then whether the patient has effusion. And again, record the flow rates on your images and be consistent with your windows when you're making these assessments. So the inflow cannula is at the apex of the left ventricle, and we can assess for obstruction in this setting. And sometimes that assessment needs to be positional. This is an example in both 2D on transesophageal echo and then 3D on the two images on the right side of your screen. This patient was having what was thought to be positional syncope when he sat up with his HeartMate device. And so we anesthetized him and then put him in various positions and then assessed the inflow cannula to see if there was any inflow obstruction that was happening depending on the position he was in. And we actually didn't find any, but it was a really good method to help us determine if there was a problem with the cannula or not. And then you can Doppler that cannula, and what you're looking for in this situation is laminar unidirectional flow without regurgitation. Cannula obstruction can occur as a result of clot or vegetation or apical hypertrophy. So as in patients who have hypertrophic cardiomyopathy who are on these devices, this can occur. And you can see that pulse Doppler of the inflow cannula can lead to these periods of abnormal obstruction of flow because of compression that you see in this example here. And so we can do those types of assessments. You can also have inflow valve regurgitation, which can be from deformation of the inflow valve or abnormalities in the leaflets of the valve, or it can be from increased afterload to the VAD, such as hypertension or outflow cannula obstruction. And it results in a dilated, less decompressed left ventricle and will lead to the aortic valve opening more frequently. And to just touch upon that, a closed valve indicates an unloaded ventricle. You don't want the valve opening too much. You want to be able to be pulling the blood away from the valve, and so it shouldn't really be opening. But you do want to have some intermittent aortic valve opening to potentially reduce the risk of late thrombosis as well as valve fusion. If the valve continues to stay closed for very long periods of time, the leaflets can fuse together and not open. And you can use M mode to help you assess for aortic valve opening as well. Sorry, the images are not playing well. And then the outflow cannula, you can have increased peak velocity if you have obstruction within the cannula or thrombosis or impingement by surrounding structures. And we also Doppler the descending aorta to be assured that we have free flow getting to the body with the devices. And then you can manipulate the VAD flow to help with decompression of the ventricle. You can see in this same patient that the ventricle was getting quite distended in the picture on the left side of your screen. And then by increasing the VAD flow rate, we were able to decrease or decompress the ventricle. You don't want to decompress it too much because you'll bring the walls together and that may cut our flow to the inflow. And so that there's a real art to figuring these things out. And echo can really help you to determine these causes. I mentioned VAD placement, and it's added when there's RV dysfunction. Here you see a very dilated right ventricle that's very poorly functioning. And once the RVAD is placed, then you can see that the left ventricle fills back up and the left ventricle assist device can work better too. So unfortunately, some patients need BiVADs. And this is a BiVAD placement in a patient we did very recently. This was a patient who had an arterial switch operation and unfortunately developed myocarditis. You can see the aortic root is dilated in that transesophageal echo. And unfortunately, the patient also had significant neopulmonary regurgitation. And you really need the pulmonary valve to be competent in this situation for the flow to be working adequately in the RVAD. The surgeon placed the cannula, the inflow cannula, in the right atrium. You can see nicely in the middle picture, the cannula with free flow, and you want to make sure that it is unimpinged in the right atrium and not causing any damage to the tricuspid valve, and there really wasn't any significant tricuspid regurgitation. And in the process of putting the RVAD in, the surgeon actually replaced the pulmonary valve, and so you can see the flow going into the pulmonary circulation just above that arrow, and there's no regurgitation of the valve there. And VAD placement in single ventricle can be quite tricky. In this example here, you see poor filling of the RVAD in this patient with hypoplastic left heart syndrome, even without the image moving, and I apologize for that, you can see that the cannula is actually up against the tricuspid valve and causing severe tricuspid regurgitation in this setting. And then the cannula was moved to the right atrium, and then the flow was adequately happening. Again, sorry that the images are not moving very well. And then you always have to be wary of device complications. This was an infected cannula that unfortunately resulted in a huge pseudoaneurysm. This is the heart here, right atrium, right ventricle, left atrium, left ventricle. And you can see a big pseudoaneurysm and a hole there that was allowing the blood to get there. And here you see some thrombus formation in the right atrium of a patient with a Berlin heart. I'm just going to briefly touch upon the Impella device, which is a catheter-based ventricular assist device that's accessed typically through the femoral artery. It is a form of temporary support in older children, typically who have myocarditis. So the hope is that this would temporarily improve their output so that it can be taken out without having to core a hole in the left ventricle. So it's the least invasive form of assist device, but also some patients will ultimately need to be transitioned to a VAD if their ventricular performance remains quite poor. And this is what it looks like on echo. We had to go through some training to learn how to assess these. The catheter is placed across the aortic valve. And you can see in the apical four-chamber view where it is at the apex of the heart. And then you can, what we're mostly looking for on the right side of your screen is for aortic regurgitation, because this catheter is placed across the aortic valve here. And we image these patients every few days and measure the distance between the valve and the end of the catheter to make sure that the device hasn't gone too far in or too far out of the heart. And so we sort of continue to measure these in consecutive echoes and compare them to each other to be assured that they're in the right place. So I again apologize the images didn't work very well, but VADs and other support devices use continue to grow because we have donor shortages, and these are really good options to support many of our patients, some of whom ultimately can come off these devices without transplant. And echo will continue to play a very key role in the surveillance. And each institution that uses these types of devices needs to develop protocols to assess the mechanisms of VAD dysfunction in these patients. And a basic understanding of the VAD and how it works is key for the echocardiographer. And so really we need to work, the echocardiographers need to work with the intensive care unit teams, perfusionists, surgeons, et cetera, to make sure we all have an understanding and a protocol that works for everyone. And this is really a team effort to care for these critically ill children. Thank you for your time.
Thank you very, very much, Meryl. It was amazing.
I'm sorry.
Really good presentation. No, but we could see for sure. And I have a lot of comments and questions to make, but I'd like to see if Dr. Silverman wants to start with his comments about this topic.
Well, I echo your remarks. I think this was a phenomenal talk. And as I sit and I listen to this, I realize as a sort of person that doesn't go to the intensive care unit much anymore, that this is a really dynamic interaction that occurs between the surgeons, often the intensivists and the other cardiology team and the echocardiographers. And the issue, I think, Meryl, that you brought out so beautifully was that you have to know about all of these devices. If you don't know about them, it's not possible to actually evaluate them properly.
Correct.
And I think that you did such an excellent job on showing us all the different devices, the different types of ECMO, and the problems that you can run into. These are the most critically ill patients that we deal with. Often it's a sort of desperation kind of cardiology. Right. And I think the other point that you made, most importantly, is that the person that is involved the most in this procedure is the patient, and
Yes.
that one has to pay attention to the patient. You cannot forget the patient. You have to be sensitive to their requirements and needs, their basic functions such as oxygenation, heart rate, pain, etc., are all terribly important in this procedure. And I think also the use of contrast echocardiography is very valuable for helping defining different abnormalities. So,
Yep.
I mean, I think that this was a marvelous talk. I know we always say that they're amazing, but this was truly amazing. And I'd like to defer any further comments until we've had the questions and answers from the rest of the audience.
It was a very, very nice talk, Meryl. Guys, please type your questions in the Q&A chat box and we can discuss further. I have some questions about how do you do on your program, Meryl. For sure, I'm sure you guys are present on the cannulation, right? To evaluate the cannula position and everything.
Yes.
After that, do you do daily echo on the patients or only when required, or you do as a protocol to do every day?
Yeah, it depends on the patient, but we definitely don't wait till something bad happens. We monitor them pretty consistently. It depends on how long they're on a device.
Yeah.
Right. So for the Impella, we tend to do it every, I think, 3 days or so,
Okay.
because the Impella can move quite a bit because it's catheter based. So for VADs, we tend to, especially if they're implanted for a long period of time, we do them weekly. If a patient is home with a device, we don't have to do it quite as often because it's been in place for a long time. But certainly a new device, we're going to see every few days initially, and then spread out the amount of time that we assess them after that. But if they're in the hospital, we do it probably weekly. And ECMO support, we tend to, because they can't stay on that device very long, right? We tend to do weaning protocols on those patients after about 3 to 5 days in the hopes that we can get them off, either off without any other additional form of mechanical support. If not, then we have to make plans towards, putting them on additional assist devices.
Thank you. Another question. One, you have a fresh VAD. Does your intensive care team is trained to do echo at the bedside, or they always need to call the echo team? For example, when we have VADs here, I like to do the echo overnight when I'm on call because I can see especially the RV, how the RV is coping with my VAD, and if the feel of the LV of the left ventricle, sometimes it helps me to adjust the speed of the pump and the rotations seen on echo. And is your team there? Do you train the team to do this at the bedside overnight, or the echo team goes and helps on that way?
Yeah, I think that is very institution dependent. And person and person who's on dependent, whoever's on. So some intensivists with cardiac training are very good at echocardiography and can make those kinds of assessments without, an echo specialist nearby. Others don't feel as comfortable. We tend to at least review the images even right after they're done, just to be sure. Even if the intensivist is involved in looking at them or performing them with a fellow or trainee. But I think that's very institution and user dependent.
Okay, I find it very, very useful when you have a fresh,
especially if you can use a handheld device to do it, and you don't have to bring a big machine over to the bedside to do it.
Yeah. That's we have the small ones, and
yes,
they for sure help.
Great use of that type of device.
And something that is very interesting that you said, and we should pay attention to that, because we are going to have, because in the beginning it was basically Berlin heart, and that was it, right?
Right.
So now we are having adult devices being used in our kids, new devices being developed. Soon we are going to have devices specifically for the single ventricle patients. So
Right.
you need to know which devices you are going to have in your program and get trained on that specific devices, because one size doesn't fit all, right?
That's
We
right.
really need to be trained in each device and learn how to look and what to look, right?
Right. We've gone through every time a new device is used. For example, when the VV ECMO cannula came into favor, and we knew that we would be helping to place, we would sort of echo guidance to place the device. We went through a training. All the echocardiographers went through a training, because you have to know exactly what the person who's putting the device in wants to know from you.
Mm-hmm.
You have to know what view will best show you that and highlight that. And we recognize that the sagittal view is a really nice view to be able to see the device going into the inferior vena cava. We've been able to detect subtle abnormalities when the device isn't working. Even just neck extension in some of these little babies can change the parameter of where the device is sitting. And we've seen, as you saw, some disasters happen when devices are not placed properly. Sometimes the catheter goes into a hepatic vein instead of the IVC and can get stuck in there. So there's a number of things but every device you use, there has to be, in addition to the training that's done for the ICU team, who obviously are going to care for the patients at the bedside with these, you need to have training for the imagers as well.
Great.
So
we have two questions. Oh, sorry, Norman.
I'm sorry. The thing that strikes me as I listen to this is that echocardiography has become too big for one particular discipline to handle all. And for example, with the people doing device closure, etc., the interventionalists have become expert at doing this, and they probably don't need us so much. And as I sit and listen to Grace talking about this, and seeing Meryl, who obviously is a pan expert at everything, but perhaps basically this is the time for the interventionalists, I beg your pardon, the intensivists, to start becoming expert at this and move this out from something that's simply handled by echocardiographers, in much the same way as we have usurped the function of the radiologist in doing angiography. When I was young, we used to call the radiologist to shoot the angiograms. Now we do that without them, and we do our own interpretation. And I'm sure that this is the trend that we will be moving in this area, because the amount of attention that is focused is largely on the interventionalist and not on the echocardiographer. There's often a team of echocardiographers who have got greater or lesser skill in this area, and you can't always get the echocardiographer with the greater skill to do your procedure. So I think it's time for the interventionalists, I beg your pardon, the intensivists, they sound so similar, the intensivists to step up and learn some echocardiography and do their own tests.
I think this is something that is important. I see very clearly two different roles. I think the echocardiographers, they have a very specific, much more trained, much more finesse to see things. And the intensivist needs to learn what's going to be important for their bedside decisions, taking care of these patients. I don't see us making diagnoses and complex things, but I think it's very important for us to see volemia, pericardial effusion, tamponade, cardiac function, and a block BT. This kind of things is important that intensivists that are in the bedside can learn. And for example, post-op of LVAD, echo is very, very, very useful. For me, it's one of the most important criteria for you to decide what to do when the patient is still after bypass and stable, for you to understand what is going on and how it could help the patient. So I think we should get more trained in echo for sure, but it's a different training. It's much more a functional bedside training on ECMO than what you guys do so amazingly with the beautiful images and beautiful diagnosis.
It's a form of POCUS, really. I mean, that's really
that's it.
That's right.
That's
Point
it.
of care
That's
ultrasound.
it.
it really is.
That's it.
We have POCUS, we have neonatal echo all of a sudden, where the neonatologists have really taken ultrasound into their own areas. And it's an evolving technology.
Yes.
I want to ask
it is.
Meryl an important question. Meryl, when you get a call to the ICU for doing an echo, do you send your technologist or do you go yourself? I think this is a very important issue.
If there is so it depends on what's being asked, right? So some questions in the ICU are not urgent, right? So some of them are a post-operative study or, whatever.
Yeah.
If it is we have advanced fellows. So if there is a new baby who is stable, known ductal dependency from prenatal diagnosis or something like that, I don't feel that I have to be in the room when it happens. But if there's any urgent situation, any urgent question, any instability of a patient, then we come to the bedside. Just like we're in the bedside, always in the operating room and in the cath lab. Those are never done without the attending physically present. And so if there is a patient in crisis of some kind, then we will be present. And we're usually present for all the weaning trials as well from devices. So it really will depend on the urgency or sort of emergency of the situation. If the intensive care unit doesn't understand why something is happening, why a patient is suddenly cyanotic or suddenly becomes hypotensive or has just come back from the operating room and something has happened, then we are present for that.
Yeah, and of course, you all have remote monitoring. So whether you're there exactly in physical presence, but
we can look at them instantaneously.
Yeah, not everybody has that facility. And if you don't have that facility, I've always wanted to be at the bedside for critical issues. And I think that's important, especially when there are questions of life and death that are involved. I think that you have to still be at the bedside.
Absolutely, I totally agree.
And the other thing that struck me is I'm so happy that we have the Congenital Heart Academy YouTube channel so that I can listen to your talk again and again and keep on learning from you. Thank you very much, Meryl.
You're the best, Norman, always.
No, you are, Meryl.
Can I say that
Mutual Admiration Society.
Oh
All right.
We have two questions from Mohammed Abdullah, and he's asking first, what is the significance of aortic valve opening in VA ECMO? And then he's asking about how to assess if a patient on ECMO requires septostomy.
Well, I think you can answer the first question, Grace.
Okay, sounds good. So in the clinical perspective, if the aortic valve is not opening and you have a biventricular patient without shunt, that is the most important population when this issue happens. For example, myocarditis, dilated cardiomyopathy, or post-op of biventricular circulation without shunt. If you are on ECMO and your aortic valve doesn't open, your LV is going to start to be distended. And the distension of the LV is going to lead you to a lot of complications that are going to impair the recovery of the function of the heart, is one thing. For example, you're going to decrease your coronary perfusion, you're going to increase the stress in the wall, you're going to pass from starting possibility of contraction again. So this is one thing. So you're going to impair your recovery. Another thing, okay, can lead to pulmonary edema. Then you're going to damage more the lungs, and then you're going to as well to make more difficult for the patient to recover from ECMO, so from whatever happened for him to be on ECMO. So you want your aortic valve to open, even if the function is very depressed. You want your aortic valve to open at least a little bit, enough to decompress the LV. If you're not able to reach there, if this opening is so tiny that you cannot, your LV is still distended, then you have to use other methods, for example, Impella, for example, atrial septostomy, to decompress the LV. But it's something that is very, very important during a VA ECMO run on a biventricular patient, is to be 100% sure that your LV is compressed so your patient can recover.
Exactly. I couldn't have said that better myself, Grace.
Thank you, Meryl.
The question about how you assess for whether they need a septostomy or not, there's no hard and fast rules about that, but you sort of, in serial imaging of these patients, you look to, and you have side-by-side comparison with digital imaging, you look to see if the left atrium is becoming distended, if the atrial septum is bowing into the right atrium, if you see the left ventricle getting more enlarged because, of all the things that Grace was just talking about. And if you start to see that happening, and in particular, if the performance of the circuit is not adequate, then these would be the indications to do a septostomy in that setting.
Great. We always try to avoid the septostomy to a certain extent. So you try to manage the flow. Sometimes you try to use a little bit of inotropic support, sometimes vasodilation. So you try, Impella is a good thing for that as well. So you try to avoid the septostomy, but you never postpone the septostomy because you don't want to do it. You try, if it doesn't work, then you go to septostomy. You should not be scared, but you should have respect to a septostomy.
And then you don't really want the atrial communication if you then go to VAD support, right? So
yes, that's it. And then
so sometimes you have to close the hole that you've made, in order to.
And sometimes a way to decompress the LV is just to move forward to LVAD.
Right, that's exactly right. Yeah.
Okay, there's another question. Can you please, Meryl, give a short list of parameters that should be measured, monitored on daily basis on VA ECMO?
On the daily basis. We don't always do it daily, so just to say that out loud, so people don't think they have to assess the patient every day. As I said, echo is not non-invasive. You have to weigh the risks and benefits of actually doing the imaging on the patients and potentially putting them at risk for an infection because we are exposing them to, another person, gel, things, even though we do the best we can, we certainly don't want to put patients at risk, and their hemodynamics can be compromised by us pressing on their bellies and chests when we're doing this type of imaging. But we generally, the things I showed in the protocol, we look at function, we look at AV valve regurgitation, we look at the aortic valve opening, we look at cardiac output by measuring VTI, and that helps to tell us if things are starting to come back or not. But as I also said, echo is not the only measure to tell you if a patient is ready to come off ECMO. You need to use all your other modalities, lactate levels, acidosis, aortic pulsations, central venous pressure, et cetera, looking at your gases and your gas exchange to see if, as you wean the patient from ECMO, that they are able to sustain their cardiac output without the support. And it's not always easy to tell, but patients who have myocardial stun or who have myocarditis often have a recovery that's really adequate and allows us to separate them from ECMO without having to put them on additional sources of mechanical support. Do you have anything to add, Grace?
Oh, I have something to add. I wish Grace had a light on so we could see her better.
I'm so sorry, Norma, I'm so sorry. I have a lot of family here in my house. Today is already a weekend here. It's Friday in the Middle East. It's a weekend. And I have so many family inside the house that I'm hidden in the balcony. That's the only place I can have some
I know.
peace.
I can see that. And I want to wish you a Merry Christmas because I can see all your Christmas festivities.
Yeah,
this is true.
The only thing you don't have in Qatar, you don't have snow.
No, not at all. We are
have
really in the winter. It's 25 degrees.
You're getting ready to watch the football.
Yes.
Oh, Norman, let's not talk about it because Brazil lost. It was-
Brazil
Yes, I
lost.
saw that. So
yeah, it
sad.
was so sad. Yes.
Well,
And I
thank
had
you very-
conditional tickets, so I don't have tickets for the finals anymore.
Oh dear. What a
Guys,
pity.
thank you very much. Thank you guys
you.
for attending this meeting. I'm sure you all learned a lot. I've learned a lot. And please share this a video that's going to be there on YouTube with your teams. I'm sure this is a very important topic, and everybody's going to be able to learn from Meryl and from Norman. Thank you,
And
guys. Thank you,
excellently
Meryl. It
handled.
was amazing.
And
Happy
just
holidays,
remember, Monday
everybody.
we'll be back. We'll be
yes.
back on
Yes.
Monday morning. At my time, 7 a.m. I think it's 4 p.m. Rome time, to discuss ecomorphological correlations
It's
in ventricular septal defects of all kinds.
going to be amazing.
Not a controversial topic, right, Norman?
A non-controversial topic. Put your
No
knife away.
controversy over that at all.
Put your knife away.
Happy holidays, everyone.
Thanks. Same
Thank
to
you,
you.
guys. Thank you very
Bye.
much.